All right, good morning, Onslow EMS. Coming to you from Camp Lejeune today with Dave Grobdahl, talking about spinal immobilization, which is probably one of the most contentious topics in EMS. The decision whether to put somebody on a backboard versus not immobilize them, whether to put them in a C-collar or not. This is often debated between physicians and paramedics, and really nobody has a great answer. One of the issues that often comes up is people tend to transpose practice rules or practice guidelines with one another. So the Nexus criteria, which was the first criteria that came out in '96, people often substitute that for lack of backboarding or actually backboarding when we're not supposed to backboard based on the Nexus criteria. So it's very confusing. And I often have a difficult time deciding whether or not somebody should get a backboard or not because of concern for spinal injury. How did we get to C-collars? So in 1979, one neurosurgeon by the name of Bowman evaluated 300 patients, and he found that 100 of them had delayed paralysis that he attributed to unstable spinal fractures. Now, if we were to do the same study today, we obviously would not do a single site with a single reviewer. I mean, basically, this was expert opinion. And from 1979 there on, we have been on this backboard and C-collar craze. When I went through EMT in 1996, I remember you weren't allowed to breathe unless somebody was in a backboard and C-collar. If the person came there for a cut finger, they got C-collared and backboarded. However, we know that backboards are not totally safe. They do a lot of damage. One of the biggest things they do for our unstable patients is they decrease their functional vital capacity, their FVC. So just like if I was to lay somebody flat on a board and then strap them down with the chest straps, they're not going to be able to take a deep breath. And if somebody is already having difficulty with breathing as far as they have pre-existing COPD or heart failure, or they've got pulmonary contusions and pneumothorax, I'm not helping them by robbing them of more oxygen. The other thing is it causes pressure sores. It only takes about 30 minutes for a pressure sore to develop on that backboard. That's easily a transport time from the scene to the hospital. So let's get the rules straight first. Nexus. Where does Nexus apply? Nexus is to evaluate the cervical spine and the cervical spine only. There's another tool called the Canadian C-spine rules, and I have sent this to Dave. He'll probably get it out to you guys, but the Canadian C-spine criteria versus the Nexus rules. For EMS, just completely delete Canadian C-spine rules from your memory bank. It's really not usable because all the patients that it's excluding or that says it doesn't pertain to are your patients. You have to be an adult. You have to have a low mechanism of injury. You can't be elderly. I mean, so you're already 1, 2, and 3. Like we've already taken those off the table because they don't pertain to EMS. Nexus is pretty helpful though. And there's a lot of acronyms on how to remember Nexus, but really it's midline tenderness. It is evidence of intoxication, and that could be either alcohol, drugs, or something else. A normal level of alertness, so a GCS of 15 and alert and oriented times 4. No focal neurologic deficits, and then here's the hang up: no painful distracting injuries. And we go back and forth about what a distracting injury is. So for what I may consider distracting injury, you may consider it not, and vice versa. But that is for cervical spine immobilization only. If all 5 of those are present or are negative and can be met, then by the Nexus criteria, does that mean you'll never miss a cervical fracture? No. What it means is you'll miss one unstable cervical fracture in 80 years of practice. And I don't plan on practicing for 80 years. I hope you don't either. But that doesn't mean that it's completely zero. Nothing that we do in these rules is ever zero. Talking about backboards, who gets backboarded and who doesn't get backboarded. So I'm holding the NAEMSP, or the National Association of Emergency Physicians, position statement on the use of backboards, which was a joint venture with the American College of Surgeons Committee on Trauma to decide who gets backboards, because we talked about respiratory compromise and pressure sores and all the badness that comes. The appropriate use of backboards includes blunt trauma and altered level of consciousness, spinal pain, or tenderness. So how do we define spine pain? It's pain anywhere in the back. Doesn't have to be midline pain, doesn't have to be vertebral pain, because we know that patients don't always localize appropriately when they're injured because they have a hard time comprehending where that pain is coming from. Anybody with pain on their back should be immobilized. A neurologic complaint, quite obviously, if you have a limb that's out or a complete myotome that doesn't work, you should immobilize them. Anatomic deformity of the spine, if it looks like an obvious fracture, you have a step off, you have bony crepitus, then you certainly want to immobilize that spine either. And then the high energy mechanisms of injury with drug or alcohol intoxication, inability to communicate, i.e. GCS is less than 15, they cannot give you a reliable exam, or a distracting injury. So we're back to the distracting injury again. Most people define a distracting injury as one or more long bone fractures. So that could be a femur, that could also be a finger. It really depends on how somebody tolerates pain. Those who should not be immobilized on a backboard: normal level of consciousness, GCS of 15, no spine or tenderness or an anatomic abnormality, no neurological findings or complaints, no distracting injury, and no intoxication. So how do we put this to bed here in Onslow County? I would follow these rules. If they have GCS of 15, they're not intoxicated, they have absolutely zero spinal pain or tenderness when you palpate their spine, and they don't have distracting injuries that you're concerned about, then those patients can be omitted for the backboard. What do we mean by omitted for the backboard? So many folks have taken to that the stretcher and the cot's foam mattress is good enough for immobilizing that spine, and in truth, it probably is. So we use the backboard as an extrication tool. As we're coming out of the vehicle, as we're doing the trench rescue, whatever, we're immobilizing that patient to prevent movement of the spine during extrication. But once we've got them packaged on the back on the gurney and go into the hospital, that patient's fine to have the backboard removed. Because we know about FVC and we know about pressure sores. So when we are immobilizing somebody's spine, we can still put them in a cervical collar, but they have to be in a position of neutrality, which means they have to be complying completely flat. Now, are there exceptions to this? Absolutely. If somebody can't tolerate lying flat because they have COPD or CHF, or because they have a pneumothorax that you've now decompressed, but they still have the resisting subsequent pneumothorax, they may want to sit up, and they're going to be very difficult to manage. But you really need to try and do your best to maintain spinal neutrality and keep that patient on a level 0. That's all I got for you now. See you guys soon.